Topic is the velocity of blood flow, and the velocity of flow changes as blood travels through the systemic circulation. It's the fastest in the aorta and the slowest in the capillaries, and then it increases again slightly in the veins. The speed of blood flow is inversely related to total cross-sectional area, and because of how many capillaries we have, capillaries have the largest cross-sectional area, so they have the slowest flow. The slow capillary flow does still allow adequate time for gas exchange and exchange of other nutrients. And so we're going to see that the exchange between blood and tissues is still able to occur even though we have this slow capillary flow. Here in figure 18.18, we're seeing the blood flow velocity and total cross-sectional area of blood vessels and definitely seeing how they relate. So what we see is that we have the biggest increase in total cross-sectional area in capillaries as opposed to arteries and veins, and that's where we see the lowest velocity of blood flow. It's definitely in the capillaries. It picks slightly back up in the veins as blood flows away from the capillaries and enters venules, and then later veins, and eventually goes back to the heart via the vena cava, but that velocity never quite gets back up to what it was at the aorta. The definition we want to introduce is vasomotion. Vasomotion is intermittent flow of blood through capillaries, and this is due to on-off opening and closing of precapillary sphincters. So that vasomotion or intermittent flow is definitely seen in the capillary beds of mesenteries in the abdominal pelvic wall. Capillary exchange of respiratory gases and nutrients is our next topic. And we've talked about capillaries having as their function exchange. This exchange could be respiratory gas exchange, nutrient exchange, even waste exchange. And many molecules pass by diffusion between the blood and interstitial fluid in order to get into tissues. And essentially they're just moving down their concentration gradient. So we're seeing molecules move from high to low concentration gradients. That's actually how we get oxygen to our blood at the lungs. There's going to be a higher amount of oxygen in the alveoli or air spaces of the lungs, and as that blood of the pulmonary capillaries flows by these air spaces, the oxygen diffuses through a thin membrane into the blood. So just keep in mind that we're using diffusion. If you need a review on diffusion, it's talked about in detail in chapter 3 of your lecture textbook. The molecules that diffuse are going to be able to use 4 different routes to cross a capillary. So we can have direct diffusion, or what's called simple diffusion directly through endothelial membranes. Endothelial membranes are the cells that we find in the tunica intima of blood vessels, but for capillaries, we only have the tunica intima, so it's this thin membrane through which substances can diffuse directly. An example would be a molecule that's lipid-soluble, because those lipid-soluble molecules could get through the plasma membrane without any channel or help needed. So not even any ATP, because diffusion is a passive process. So lipid-soluble molecules such as respiratory gases are very easily going to directly diffuse through thin membranes. We could also say that molecules could pass through intercellular clefts, and of course they could pass through intercellular clefts if they were bigger, so it's a little easier than fenestrated capillaries as opposed to continuous capillaries. An example of something that can pass through an intercellular cleft would be a water-soluble solute. Some substances pass through the pores or pass through fenestrations, and things that could pass through fenestrations also include water-soluble solutes. So water-soluble solutes could pass through large enough intercellular clefts and fenestrations, or the pores we find in the endothelial cells at some capillary beds. And active transport is possible in capillary beds. It's just not commonly used. But we can use active transport and create penocytic vesicles or calveoli in order to move larger molecules such as proteins in and out of capillaries. So here's just a general capillary bed. This one is specifically a fenestrated capillary bed. So it does contain intercellular clefts and fenestrations. And we could also have simple diffusion directly through the endothelial cells. Here is just figure 18.19 showing you those 4 methods of capillary transport mechanisms, including the first 3, which are passive transport, simple diffusion, movement through intercellular clefts, and movement through fenestrations, and then the last one, which is a demonstration of active transport, which can occur via calveoli or penocytic vesicles through endothelial cells. Next, we're going to talk about bulk flow or fluid movements through a capillary bed. And in general, fluid is going to be forced out of intercellular clefts of capillaries at the arterial end, and then some of that is going to be sucked back in or returned to the capillary bed at the venous end. It's extremely important for you to realize that there is some fluid that leaves the capillary bed and some of it that comes back, but not all fluid comes back. So that's why the lymphatic system has a close association with the cardiovascular system. It's to return that leaked fluid that doesn't make it back into the venous end of a capillary bed to the cardiovascular system. It's extremely important also in determining relative fluid volumes in the blood and the interstitial space. So this exchange of fluid between the blood, interstitial space, and lymphatic vessels is going to help us determine not only fluid volumes of the blood, but around tissues and in tissues. Bulk fluid flow across capillary walls does cause continuous mixing of fluid between the plasma and interstitial fluid, and that maintains the interstitial environment. So that's the reason we find certain things like potassium and sodium and whatnot in the interstitial fluid, because of this exchange that occurs between capillaries or the blood and the interstitial space. The direction and the amount of fluid flow depends on two opposing forces. So we know fluid flow is already out at the arterial end and in at the venous end of a capillary bed. But what is actually causing this bulk fluid flow? Well, it's these two opposing forces, the hydrostatic and colloid osmotic pressures. Hydrostatic pressures are pushing pressures, so we just have to know where this hydrostatic pressure is, and it's going to push fluid away from it. So hydrostatic pressure in the capillary is going to push fluid out of the capillary into the interstitial space. So capillary hydrostatic pressure is capillary blood pressure that tends to force fluid through capillary walls. Whereas interstitial fluid hydrostatic pressure is normally zero, but what it would do if there wasn't interstitial fluid hydrostatic pressure, it would push fluid back into a blood vessel. Any excess fluid in the interspace is usually sucked up by the lymphatic vessel, so that's why the interstitial fluid hydrostatic pressure is considered zero. An osmotic pressure is a pulling pressure, so wherever this pressure is located, it tends to pull stuff towards it, mainly water. So there's a capillary colloid osmotic pressure, so that's in the capillary. So this pressure is going to pull water or create a sucking pressure that pulls stuff towards it, and the sucking pressure that's created is generally done by plasma proteins such as albumin. And this is going to help us maintain oncotic or colloid osmotic pressure. Interstitial fluid colloid osmotic pressure is relatively low, only about 1 millimeter of mercury, and this is the pressure that tries to keep water or pull water into the interstitial space, and it's able to pull stuff into the interstitial space, but because of albumin in the capillary, we are actually able to hold on to enough water to maintain the proper concentration of water in blood plasma. So albumin is really important for maintaining capillary colloid osmotic pressure. Next, we're going to look at hydrostatic osmotic pressure interactions, and this all begins with net filtration. Net filtration pressure comprises all the forces we just got done talking about. The abbreviation is NFP. NFP is equal, you see here, to the hydrostatic pressure of the capillaries, the oncotic or osmotic pressure of the interstitial fluid, minus the hydrostatic pressure of the interstitial fluid, plus the oncotic or osmotic pressure of the capillaries. But essentially, it's a kind of amalgamation of all the forces acting on a capillary bed. And net fluid flow out at the arterial end and net fluid flow in at the venous end is occurring because of the net filtration pressure at each end of the capillary bed. We would term the net fluid flow out at the arterial end filtration, and the net fluid flow in at the venous end reabsorption. We do know that more fluid leaves at the arterial end than is returned at the venous end, and it's that excess interstitial fluid that will be returned to the blood via the lymphatic system. We'll talk more about the lymphatic system in chapter 19. This is a good focus figure because it is showing you bulk flow across the capillary, and we can see that here's the arterial end, here's the venous end, and at the arterial end, the arrows are pointing out. At the venous end, the arrows are pointing in. And we even have a lymphatic capillary with an arrow pointing in. And what this is showing you is that fluid is pushed out of intercellular clefts at the arterial end of the capillary bed and then pushed into intercellular clefts at the venous end of the capillary bed. And any excess is sucked up by capillaries of the lymphatic system and eventually returned to the cardiovascular system. So bulk fluid flow across capillary walls does cause continuous mixing of fluids in the interstitial space and in the plasma inside the capillary blood vessels. And so this mixing is helping to maintain that interstitial environment. You also have in your focus figure these kind of U-shaped beakers, which I would say are helpful in just getting a general idea as to what these pressures are doing. But I would focus mainly on studying that last image and just looking at that terminology again and again for hydrostatic pressures of the capillaries versus interstitial fluid pressures of the capillaries, and vice versa for hydrostatic versus osmotic pressures. So again, hydrostatic pressures push, osmotic or oncotic pressures pull. Your book uses sucks, but pull is fine too. And that's what they're just showing you in these U-shaped beakers. I do like this part of your focus figure looking at each side. So we're going to start at looking at net filtration that occurs at the arteriolar or artery end of a capillary. And you see here that the hydrostatic pressure inside the capillary is our largest pressure. So no matter what other pressures are being exerted, we have an oncotic pressure of the capillary pulling fluid in. The pressure that's the largest is going to win, so our net filtration pressure is going to be out, but only out by about 10 millimeters of mercury. Here at the venous end, we're seeing net reabsorption, but there's still a net pressure, and that net filtration pressure is going to be negative, and that's when we know it's reabsorption and not filtration. And the hydrostatic pressure of the capillary is about 17 millimeters of mercury, but much bigger is the oncotic pressure created by the pulling force exerted by albumin. Kind of has its own gravitational force and pulls water towards it. And the other two pressures are basically negligible. So total, our net filtration pressure is going to be in by negative 8 millimeters of mercury. We also want to acknowledge a clinical or homeostatic imbalance. That would be edema or swelling. This would be if abnormal amounts of fluid seeped into the interstitial space around tissues. That would cause edema. This is, again, an abnormal increase in the amount of interstitial fluid. And it can be caused by either an increase in outward pressure, so something driving fluid out of the capillaries, maybe a blood clot that makes it where fluid has nowhere else to go but out into the tissues, or maybe a decrease in inward pressure if there's something wrong with the amount of albumin or plasma proteins that you have in your blood. But something's generally causing an increase in capillary hydrostatic pressure that accelerates fluid loss from the blood, and this could be due to incompetent venous valves, blood vessel blockage, like I said, or congestive heart failure, even high blood volume. An increase in interstitial fluid osmotic pressure could result from an inflammatory response, and that inflammation would increase capillary permeability and allow proteins to leak into interstitial fluid, and this could cause a large amount of fluid to be pulled into the interstitial space. So essentially what we're seeing here is that an increase in interstitial fluid osmotic pressure can occur if we somehow lose plasma proteins like albumin to the interstitial space, then albumin acts there instead of inside the blood to pull fluid towards it. There could also be a decrease in capillary colloid osmotic pressure that would hinder fluid return to the blood, and that could definitely cause hypoproteinemia, which is low levels of plasma proteins, and that could be caused by malnutrition, or liver disease, or glomerulonephritis. The loss of plasma proteins from the kidneys would be what glomerulonephritis is. So hyperproteinemia is also dangerous because we do need a certain amount of plasma proteins in your blood to keep water there, to keep fluid there. And so if we have something that disrupts that, it could cause a decrease in that capillary colloid osmotic pressure, and therefore fluid would not want to necessarily return to the blood and would stay in tissues, another thing that could cause edema. But edema can also be caused by decreased drainage of interstitial fluid through the lymphatic vessels. A blockage in the lymphatic vessels could be what causes. They could be damaged surgically, or something could be developing that's disease-related. But whatever it is, this excess interstitial fluid in subcutaneous tissues is generally going to cause problems. One kind of, I guess you could say, aesthetic problem would be pitting edema, which would be where you could push down on someone's, say, foot, for example, where the edema is occurring, and it would actually cause like a pit to form. We'll see a picture of that coming up. But edema can impair tissue function as a result of increased distance between, say, the blood and the tissue cell itself. And if you increase distance, it's going to decrease the ability of diffusion to occur. So this could keep tissues from getting respiratory gases, getting rid of waste products, getting nutrients, all of that stuff that occurs when capillaries are in close association with their tissues. So slow fluid losses can be compensated for by renal mechanisms, but any rapid onset, which may result in edema, may have serious effects on the circulation. So we could see that this fluid moving into tissues has an effect on blood volume and blood pressure and how well the heart thinks it's efficiently pumping. Here's just an example, figure 18.20 of pitting edema. So in this individual, fluid has moved into their tissues, and they definitely are at risk for their tissues suffering from not being able to get enough oxygen or nutrients because of that increased distance between, again, capillaries and tissues. All right, next we're going to be looking at some circulatory pathways in the body. So make sure to watch that part 3, and we'll just be highlighting some major points. There's not much more, so just stay tuned for that video as well.